just to remind ourselves of the basic anatomy and what to do when we see one. I really wish I had more time to do more preparations, if I can put it like that, for this, but I have tried to put some things together. Unfortunately, in this particular preparation I have made, I did not put the images of my patient. He had a CT scan and an MR angiogram. But maybe on our WhatsApp page, I'll forward those images again later. And also, I think about 9 months or so ago, Dr. Okafor had made a presentation on carotid cavernous fistulas in our 2 monthly webinars. I'll post that link as well on our page so that we all have it, or Dr. George can help us with that so that we can all have it and use it to refresh in our memories as well. Okay, so I'll go ahead. George, is there any way you can help me remove this thing from my screen? I can't move forward. George?
Yeah, the screen has just moved.
Okay, so I'm the only one seeing the thing. This meeting is being recorded. It's only on my own side of the screen. Okay, that's fine. I can go ahead.
Just click on OK.
Just tap it. It will just tap
yes,
OK.
say OK, and it will go away.
The problem with this my laptop is I can't do that. I'll have to scroll all the way to the end of the presentation, stop share, do that before I go back to the share again. So okay, let me see.
Is it obstructing your view? Are you?
Yes.
Okay, fine. You can do that.
Yeah, let me just get to the end. Good. So good. All right. So now I can go back to the top and start again.
Sorry,
maybe I haven't gotten to the computer yet. No, it's fine. All right. So I'll go through the carotid cavernous fistula using this outline. And simple definition of carotid cavernous fistula: from the name, a connection between the internal carotid artery and or its meningeal branches and the cavernous sinus. And I'll want to quickly go through what the normal anatomy looks like. We're more interested in the cavernous part of the ICA, which according to various classifications is usually described as the C4 segment. It starts at the petrolingual ligament and then ascends to the posterior clinoid process, passes forward by the side of the body of the sphenoid, and then curves upwards on the medial side of the anterior clinoid process to end at the proximal dural, the distal dural ring. Okay, so this is what it looks like pictorially. We can see how it ascends and then goes forward and then ascends again. That's also known as the carotid siphon. And I think we can see the labeling very clearly. This is how it goes through the cavernous sinus. I think I have another image that shows it even more beautifully. So we can see the C2 segment of the ICA, the C3 segment, and you can see on this B image, you can see the petrolingual ligament there, and the cavernous segment of the ICA starting from that point. And we can see it ascends, goes forward, and ascends again. That green area there, that green part of the ICA, that is the cavernous segment of the ICA. Okay, and this shows it on a digital subtraction angio image. It's well labeled. We can see the petrolingual ligament there, and that area is called the carotid siphon. We can see as it makes that kind of S shape before giving off the ophthalmic artery, and then now dividing into its terminal branches. Okay. So this shows the relationship of the ICA to the cavernous sinus. Okay, and I'll be talking about the cavernous sinus in a few minutes. We can see how it passes through the cavernous sinus there. And it's very interesting to know that all of this while the internal carotid artery is extradural. It is when it passes through the distal dural ring that it becomes completely intradural. Okay. Now the cavernous sinus is a paired dural venous sinus, one on each side of the pituitary gland. And it borders anteriorly. We have the superior orbital fissure through which the inferior and superior ophthalmic veins pass through to drain into the cavernous sinus. Posteriorly, we have the petrous part of the temporal bone. Medially, of course, is the body of the sphenoid bone. And then the roof and the lateral edge of the cavernous sinus is covered by the meningeal layer of dura, and then the floor is the endosteal layer of dura mater. This autumn CA is a mnemonic to help us remember the contents of the cavernous sinus, which is very helpful because it helps us to also see how patients present with different neurologic manifestations when we have. And then the autumn part is talking about the contents of the cavernous sinus from superiorly to inferiorly. Lining the lateral wall of the motor nerve, T for trochlear nerve, or the second O for the ophthalmic branch of cranial nerve 5, and the M for maxillary branch of cranial nerve 5. And then the CA goes the lateral way from medial to lateral. That's horizontally, sorry, from medial to lateral. The C stands for the carotid artery, the internal carotid artery, and then the A is for the abducent nerve. So this helps to just remember the contents of the cavernous sinus. And this is a pictorial demonstration of what I have just described. The roof, the lateral border, the floor of the cavernous sinus. And of course, we can see the red circle there showing how the internal carotid artery passes through the cavernous sinus. All right, and we can also see the close relationship with the sphenoid bone and the sphenoid sinus. And this has really importance for the etiology of carotid cavernous fistulas. Sometimes, very rarely, you could have a carotid cavernous, when you mistakenly nick on the internal carotid artery. You may think you have of that, but it could keep slowly leaking into the cavernous sinus and form a large fistula thereafter. Another pictorial demonstration of the carotid artery and the cavernous sinus anatomy. I put this one just to help us identify artery is in relation to the cavernous sinus. The top images are CT scans, the middle images, MRI, and the bottom image on the bottom bottom images, the two to the left are MR angiograms. So it just helps to show us the carotid artery, the cavernous segment of the carotid artery. Okay. Now the cavernous sinus receives drainage from the ophthalmic veins, both superior and inferior, the central vein of the retina, the sphenoid parietal sinus, the superficial medial cerebral vein, which gives us a good connection with the superior sagittal sinus, and then the pterygoid plexus. And it empties into the superior and inferior petrosal sinuses, and from there to the internal jugular vein. Okay. So this is a very good pictorial representation of the venous structures, the cavernous sinus, and the place labeled the circular venous plexus shows the intercavernous connections, both anterior and posterior. So that whole area is just a plexus of veins. Of course, the cavernous sinus, we know, is not just a simple space. It is actually like a cave. It's divided into various segments by various septa. So it's not just one huge space like that. It's actually divided into compartments, if I can put it that way, okay, by septa. All right. I like this image because it shows how the superior and inferior ophthalmic veins pass through the supraorbital fissure to drain into the cavernous sinus. We can also see the central retinal vein draining into the cavernous sinus. And one other very important thing to note here is the connection that the superior ophthalmic vein makes with the facial vein. Right? I don't know if you can see that connection. I don't know if my arrow would show it, because I can't see my arrow from my side, but it's well labeled and we can see. So when we have this carotid cavernous fistula, we can easily appreciate why the patient will have the retroorbital, we'll have proptosis, and we'll have a bruit, following a carotid cavernous fistula. Okay. Now, CCFs are basically divided into direct and indirect carotid cavernous fistulas. The most widely used classification is the Barris classification. This was done to there are various other classifications, but this one is relatively easy and has been able to hold people's attention for this long. So in the type A, basically, it's a direct carotid cavernous fistula where there's an internal carotid artery as it passes through the cavernous sinus. So it's directly leaking blood from the ICA into the cavernous sinus. In the indirect types, it's not the ICA directly, but branches of the ICA that are linked with the cavernous sinus. So in the type B, they are okay, very good pictorial classification of that. In the type B, we have branches of the meningeal branches of the ICA connecting with the cavernous sinus. In type C, we have branches of the ECA. There's carotid artery, and then in type C, connecting with cavernous sinus. These are known as indirect CCFs or true arteriovenous fistulas. Okay. Now, the type A is common in young males and usually post-traumatic. And it used to be common before the advent of airbags. For me, in my whole patient that I have seen with the carotid cavernous fistula, he's a 19-year-old, and there was a history of trauma. He was involved in a fight. Actually, this one was not a road traffic accident. He was involved in a fight. Somebody hit him on the side of the face. And then a few months later, he began to hear this noise in the head. And then he began to feel that pulsation on the side of the head. And that was what led him to, and then the eyes started bulging, and so that's why he presents. I have given a typical example from the one that I have seen. So there's usually an acute onset of a loud orbital bruit with proptosis, chemosis, sometimes conjunctival eversion, corneal abrasions when the eye is really pushing out, and palsy of the cranial nerves are associated with the cavernous sinus. And sometimes the volume of flow can rise so rapidly that you begin to see features of venous hypertension and even raised intracranial pressure. And at this time, you definitely need to should I say hurry up, to offer management on an emergent basis. So clinically, the diagnosis is usually straightforward, unless the patient presents in some other uncommon ways. I was listening to the presentation by Dr. Kapo, where he mentioned that a patient can present with epistaxis, and of course the patient will go to ENT and they'll be there trying to sort out the epistaxis, not knowing that it's probably one venous varix that is protruding down from the cavernous sinus into the sphenoid sinus that has bled. So sometimes they may present in not so straightforward ways. So we can't just take it very lightly. You can almost certainly say that this is what this patient has. For instance, when I saw the young man in my clinic, I had never seen a carotid cavernous fistula before, and I can't even remember when last I read about it until I saw the patient. But just hearing that bruit and all of that, I could almost say for certain that what he had was a carotid cavernous fistula. But then you have to go ahead and do imaging, and when you do a CT scan, you might be able to pick the dilated tortuous superior ophthalmic vein. You might be able to see the internal carotid artery, and you, at the point where it gets into the cavernous sinus, you might not really see much afterwards, and then the next thing you see are the dilated veins. You can still go ahead to do other brain imaging, CT angiogram, MR angiogram, but the diagnostic imaging of choice is to do a digital subtraction angio. And even on digital subtraction angio, the abnormality is obvious. However, what we really need to know is where exactly the tear is and how extensive it is, because that's the only way we'll be able to appropriately treat the lesion. So when you do the run through the ipsilateral ICA, you might not be able to get that exact location of the tear. So to help identify that, you may need to get images from the rest of the circle of Willis. And so it is recommended that when a patient has a CCF, you should do a 6-vessel angiogram so that you can look at it from all the different angles, especially from the vertebral artery. Reflux from the ipsilateral PCOM is often the best way to be able to identify where that tear is, because you will see where that reflux, at the point where it gets back into the ICA, is where you'll be able to identify the distal end of the Also on the data cerebral internal carotid artery, on deciding how to manage the patient, you may want to see if you can salvage the ICA or if you can sacrifice the ICA. And to say that if you're able to get adequate flow through the supraclinoid ICA from the circle of Willis, then it means that the ICA can be safely sacrificed, because that means that the flow to that part of the brain is adequately maintained by the circle of Willis. Now, what are the treatment options? Of course, when you see a patient with a direct fistula, treatment for the patient. However, in some other situations, it might be more prudent to wait and observe the patient. So that's why I wrote watchful waiting. For instance, in our textbook, there's this description of an elderly lady who came in with a CCF, and a few weeks later, it spontaneously regressed, and when they repeated the DSA, it was no longer there. There was a good revascularization. So I can't remember what type of CCF she had, but most likely it was a low flow indirect carotid cavernous fistula, which may be able to spontaneously regress. Okay, but most times when you have a direct carotid cavernous fistula, you would need to go ahead to treat the patient. Now, in times past, the different treatment methods that have been given include carotid ligation and autologous muscle embolization. And I would really recommend that we go back and listen to that presentation by Dr. Kafo, because he gave a very nice description of how his boss, one of his bosses in previous times, did that in the 80s, I think, before endovascular treatment became available. Okay. And in the era of endovascular treatment, it was the use of detachable balloons was also done. They used latex balloons and or silicone balloons, pass it the artery and detach it. So, but there are a lot of complications from using this method, and it is now no longer really being advocated for. Currently, the main endovascular approaches to carotid cavernous fistula is to either trap the ICA and close off the fistula, or try to preserve the one. We have three main approaches: the transarterial route, the transvenous route, and the combined approach. The transarterial route is more preferred. However, you may need to, use a number of, should I say, tricks of the trade to be able to achieve that, because being a high flow lesion, you might find it difficult to deploy your coils or deploy your what's the other one that is being used? Coils and stents. Okay, so you may need to use different approaches together to be able to achieve what you want. Okay, here I wrote about the indications for urgent endovascular treatment, which include venous hypertension, increasing proptosis or reducing visual acuity, increasing intraocular pressure, raised ICP, or sometimes you have rupture into the subarachnoid space. These are all indications for urgent endovascular treatment. So The transvenous approach, I really haven't seen that being done. I mean, it's not like I've seen anyone being done for CCFs before, but I've never seen a transvenous approach for anything anyway. But it is an option for direct carotid cavernous fistula, and it's more challenging in direct CCFs because of the high volume of flow. Most importantly, though, is that the cavernous space needs to be densely packed so as to be able to induce thrombosis and like to get the desired outcome, coils and glues and covered stents and balloons and so on and so forth. Is that the end? Oh, I'm sorry, I didn't realize that I've come to the end of the presentation. After endovascular treatment, we need to watch out for a number of things, and this is very important. So we can't finish the procedure and discharge the patient home. We need to take our time, observe the patient, nurse the patient in ICU, and what are the things we're watching out for? There's the possibility of recanalization of the fistula, so we need to watch out for that. A lot of times after successful treatment of the CCF, all the symptoms stop, right? The veins regress and all those proptosis and chemosis can reverse, you know. So it's usually a very dramatic and fulfilling management once it is done properly. However, sometimes the fistula may recanalize and then the symptoms start up again. So we need to watch out for that because now you need to repeat and see how you can treat the ICA more effectively. In the textbook, there is discussion of someone who had a good treatment and I think was discharged from, and then a few weeks later, his symptoms reappeared. And so this time around, they had to go transvenous route, and they opened the supraorbital vein directly, you know, to canalize directly with the supraorbital vein directly from above the supraorbital
Hey, Dr. What, you done?
I think she's been disconnected.
I can't hear Opara again.
Yeah, I can't hear her. Is it our internet or? Okay, while we are waiting for her to come back, do we have any comments or, first of all, General, welcome back.
Thank you so much, sir. Sorry, last week I was
You're on transit.
on transit, so at the time I was on air, so I couldn't join.
No problem.
Yeah, and then the meeting on Thursday, I set an alarm to really join, but I've been struggling with sleep adjustment these days. Yeah,
That's still jet lagged. That's okay.
Guys, adult education.
Sir, you said what?
I said, oh guys, adult education, no, adult education.
I agree with you,
Ready?
sir.
That is awesome.
Yeah.
Okay.
But at least I met family well. Everybody
Welcome
is
back.
fine.
Thank God. Welcome
Thank
back.
you so much, sir. Yeah.
We're going
Hello.
Oh, yes. Dr. Bar, sorry, we lost you.
Yes. I'm so sorry. So I think my network went off completely. So I had to just reconnect back with my phone. But I hope I was able to get to the end of the presentation.
I think you did. Thank you.
Hello? Can everybody hear
Yes,
me?
we can hear you. Can you hear us?
Oh,
We can hear you.
I hear you.
okay.
Maybe we'll type in, tell her we can hear.
You had some pictures at the end of the presentation that I thought you were going to get to. But this was a
Oh, no.
fantastic presentation. The illustrations were very, very clear and very explanatory. Thank you.
Okay, so yeah, go ahead. Do you have a question for Dr. Kwar on the presentation?
Yes, sir, I do. Good evening, sir. Good evening, everyone. Thank you. Thank you for the presentation. I really enjoyed it. My questions are two. First, the carotid cavernous fistula. Is it only the cavernous part of the ICA that's involved? Because from the diagram that you showed, I know that some part of the lacerum parts and some part of the clinoid parts, they seem to be involved in the area where the cavernous sinus was. So I wanted to know if it's strictly the cavernous aspect of the ICA that is part of or that is involved in this fistula, or just maybe that's the main part, whether C3, C4, and C5 are involved, or some parts of C5 are involved. Then my second question is, when we talked about the indirect, the method of addressing the problem, when we talked of the transarterial and transvenous, what exactly is the endovascular method that is used to address it? Is it which of the tools that we have are we really? What's the aim of that tool in addressing this fistula, since probably they are not able to tie up the fistulas like in some parts of the body? What exactly is the tool that is deployed, and what is the aim of the tool? Okay.
Yeah, so Dr. Lisa, thank you for those questions. Dr. Kwar, did you hear the questions? Maybe our network is still not. Dr. Kwar, are you with us?
Where he was asking what exactly are the tools we use for treatment, and what is the goal. Well, I'm not an expert yet. I'm getting there. But from what I understand, there are two ways you can approach the treatment of CCF now. One is to approach it by sacrificing the ICA on that side, good flow to the rest of the supraclinoid area of the ICA from the circle of Willis. If you are sure about that, then you can sacrifice the ICA. And sacrificing the ICA means basically that you trap the ICA above and below the fistula. When you do that, it means there'll be no more flow into the cavernous sinus. And so all of those high flow effects will cease. Okay, now how do we achieve that trapping? From what I understand, right, is your coils, your glues, your stents, your balloons, because sometimes the tear is so large that trying to use only one thing will not help, So sometimes you may have to pack your coils across the area of the tear. Okay. So if the tear is so large, you may need to put assisted stenting, let me put it that way, to be able to achieve your packing of coils, or you may need to use some other form of stents. Okay, so you can use any of these agents, either most of the time in combination, to be able to achieve that aim. Same thing with if you have to preserve, if you need to preserve the ICA itself, you want to seal off that tear. Okay, so that the iteration where you need to really pack the venous side of this in that area, and then or whatever else to try to seal off the tear in the wall of the fistula. So that's the most I can say from a beginner's point of view, and I'm sure Dr. Kapp will be able to help us better. Thank you.
He had a second question. Is it just the cavernous segment of the IC that's involved, or could it be the lateral or supraclinoid, other parts of the IC involved? Was his first question for CC fistula.
Okay, so for the direct CCF, it's usually just that cavernous segment, okay? But for the other indirect ones, it's the branches of the ICA. So the branches may come up from I'm not quite sure now, but inferior trunk, am I correct? Inferior trunk, ILT, branches from there. There are many branches that may have a connection with the situations. It may not be limited to just the cavernous segment of the ICA.
Thank you very much. That's awesome. Anybody else wants to ask a question? Any comments? We're going to try and keep the time because we have the rest of our Lagoon team here who are participating and trying to, of course, bring themselves up to speed because of the treatments we're going to be doing. Dr. Opara's patient, hopefully by God's grace, has the CC fistula that's coming for treatment in Lagoon. So we want to try and keep the time so that they can get some rest as well. But anybody else have a question, comments about this topic? Dr. Opara, thank you so much. Done a great, great job on this. Thank you.
Also wanted to find out about the airbags and the reduction in carotid cavernous fistulae. Was there a specific type of CCF, and then why is it that airbags have played a role in reducing? Is it because of less severity of the head injuries or specific, base of skull fractures? I would really appreciate some clarification.
Dr. Opara, did you hear the question?
I think Myra is off.
Okay. So your question was, why is it that with the advent of airbags, we don't have as much of these CC fistulas? Is that the question?
It was the relation with the airbags and why did we use the.
Okay. All right. Is Dr. Barr still there? Otherwise, I could help chime in as well.
I'm here.
Yeah, go ahead. You had the question.
I'm here, sir.
That is, yeah.
I just had the ending part, but I assume we're saying that why did the CCFs drop dramatically after the enforcement of airbags, if I'm correct?
Yes.
Hello? Am I off again? Looks
No,
like
we can
I'm
hear
off.
you.
No,
We
we
can
can
hear
hear
you.
you.
Oh,
Yeah,
okay.
no. So yes,
Okay.
that
So,
was the
so that was the question, right?
yes.
Okay.
That was.
So I think before the advent of airbags, when motor vehicular accidents occur, there's a likelihood that the patient may, even with a seatbelt, may still get his face, hit from different things, from the steering wheel, from the door, from something moving through the car that wasn't restrained. So the face could get hit, and so this can occur. But with the use of airbags, when there's a collision like that, the airbag is deployed and it helps to cushion the patient. Oh, sorry, the occupant of the vehicle. Okay, so that is what has helped in reducing the incidence of having traumatic carotid cavernous fistulas. I'm sure Dr. Kaffa will be able to throw even better light on that.
Yeah, I agree. Thank you so much. That was a good answer. Dr. Opara, thank you. Kind of cushions off the direct impact on the head. So it's pretty much helps reduce the incidence. I agree with that answer. Anybody else wants to chime in? Questions?
Okay, so I have this concern with maybe clarity more with the options available, the for CCF endovascular treatment of CCF. Are there specific things that kind of indicate when you do transarterial? Sorry, I joined a bit late. I don't know that Opara came up with those, but my thoughts have been, okay, when do I use a transarterial route? When do I use a transvenous route? When do I deploy a stent? When do I say, okay, now at this point I can't do endovascular, let the microsurgical team go and do the trapping? Are there some silent maybe imaging findings or presentations that we can see and said, okay, yes, because we had a case where when I was in Barrow, and the Lawton just looked at it and said, oh, the endovascular team can do this. So, but of course, the detail as to why he just wished it away and said, let the endovascular team do it, it was not clear in my mind, so, but I think he just looked at the images and said, I think the endovascular team can do this. So, of course, that's raised a question in my mind. And then I know the endovascular guys have options to go transarterial or venous. So are there specific silent? And I know that sometimes you can deploy a time, then deploy a core. So those things are a bit, not so those specifics are not too clear in my mind. I don't know. Farah, did you come across maybe some reasons for why specific approach can be used?
Okay, thank you very much for the question. So I will answer this way. I do not see any specific indications for when to use what. What I could tell is by the time you are doing your DSA and you are able to identify the tear, there's even nothing to say about how wide the tear is for you to determine what to use, or if there are other things. Well, they mentioned some other things, like if there's a dissecting aneurysm, if there are varices, right? What else did they mention? I think those are the two things I could see. But there was no clear-cut indication to say, oh, if you see a 5 mm tear or a 7 mm tear, use this, use this, use this. No, I didn't see that. But I think the whole extent of the lesion, you cannot begin to tick off what things do I have on hand to be able to, and that is why they mentioned that you may need to use a combination of things to be able to achieve your aim. So that are a little bit more specific was when they talked about trapping the ICA versus preserving the ICA. And I think that was like the most clear-cut thing I could see, because basically from what I saw, trapping the ICA seems to be a more easier thing to do, that the supraclinoid area of the ICA is being well perfused from your from the circle of Willis, then you can conveniently just trap the ICA and that solves your problem. However, if you can't do that, then you have to ensure that you are preserving the ICA. And it is at that point that you now want to look at, should I go transvenous? Should I go transarterial? Should I use both? For those ones, I couldn't see any clear-cut, should I say, indications for when to use what. Thank you.
Okay, thanks.
Thank you very much, Dr. Opara. That's a good stab at that question. Just before we go, I know I won't try and keep us to time. I want to please recognize we have members of our cath lab team in Lagoon. The general manager of the VI branch is here. Dr. Kujiro, do you want to introduce yourself to the team? I'm sure just officially so everybody knows you.
Thank you, Dr. Okafor. Good evening, everyone, and good afternoon to those with Dr. Okafor. Yes, my name is Dr. Ayaba Mekuyoro, MD with Lagoon Hospital, Legally Victoria Island here in Lagos, Nigeria. I have some members of my team here. I have, I think Shegun was, I had the cath lab manager here earlier. Shegun was here. I have a matron Grace.
Good evening, everyone.
Yes.
And good afternoon,
Welcome.
Dr. Okafor.
Yes. Okay. I don't know if Dr. Lovett was able to join eventually, but I tried to get her on the call. Thank you for putting this together. We're, really excited and, looking forward to the next trip. The meeting we had yesterday was very useful, and we've started putting things together, all the things we discussed and all. So I'm looking forward to meeting everyone again. I have met Dr. Opara, and I think a couple of other people, members of the team, but I'm looking forward to the next visit. Thank you. Thank you, Dr. Okafor.
Thank you so much. We thank God for the wonderful partnership we have. We're looking forward to coming. So for those who don't know already, God willing, the next treatment is on 28th.
28th, but you arrive on the 27th.
Yes, so arrive on the 27th. We'll fly 26th, arrive 27th. I'm coming down with Misha. So Misha is the pediatric neurointerventionalist. So we're both going to be coming down, by God's grace. Then we'll see all the patients on the Friday. So our fellows, if you want to come in on Friday, because Saturday morning, first thing we're starting. So come in, make arrangements to be there on Friday evening. If you're around on time, we'll see all the patients together. And then Saturday morning, we kick off, God willing, the whole day, hopefully cover everybody. And then Sunday at 12, between 12 and 5, we hope to have a live conference. So Misha will be talking about pediatric neurointervention. So all these things we talked about, CC fistula, we're going to go to town. I didn't comment too much because I wanted you guys to exhaust yourselves. And then the fact that we're going through it ourselves makes, by the time we're now doing it again, it makes more sense. And it'll be live demos, live, so something similar to what we did in October. We're going to do it, but we're doing it in Lagoon. So Lagoon is going to be our flagship. So God willing, we'll do that on Sunday. Then everybody can take off. So that I think this, according to I discussed this plan with Prof. So Prof. Bankole said felt that would be the best arrangement. So to reduce interruptions to your regular work. So if you come in on Friday, you leave on Sunday, you're back to work on Monday. So I think that's great for everyone. So we really love everybody to show up, especially our fellows. And we can ask Kingsley, you can join us since you've been very consistent. Come join us. Of course, Dr. Kuyiro, please, you help us credential all these our fellows so that they will come in to join, because these are people we need to take the baton from us. Because this visit, the whole idea is that in the next 2 years, you guys know how to do this stuff and can do it on your own. And then we'll only come in for very complex cases. The bread and butter stuff you can handle by yourselves. That's the whole idea of this exercise. So the last thing I want to say is, so thank you very much, everyone. Some more comments we're going to make, but I'll hold off because I want to make sure we keep the time. And then next week, George, what do we have? Next week, Saturday.
We have AVM. Dr. General will be presenting.
Is it AVM or is it vein of Galen?
Well,
which one are we doing?
AVM.
Okay.
Except you want that both of them be done the same day, we could split it.
No, it's too much. It's too much. So, General, can you do vein of Galen instead? Because that's one of the ones, that's like #1 treatment we're doing. The vein of Galen, that's the child that is in the hospital we need to take care of. Or do you want to do the AVM instead? I know you've just come from Barris, so you'll be full of knowledge. You want to do the AVM instead, that's okay. Then we can take care of the other one or we come. Is General still here or is he gone?
Whichever one you think. Which one do you think we should take? AVM or vein of Galen?
Okay, do something. Maybe we should do AVM because you've just come from Barris. So let's listen to all the words of wisdom you've collected from the professor. So let's do the AVM. It's okay. We can handle vein of Galen when we come. On the Sunday, we'll do vein of Galen. It's okay. So thank you so much. I'll leave you to deal with the AVM. You'll be very well versed. So let's take us through the AVM. It's fine.
Okay.
All right. So thank you, everybody. Thank you for joining. We're looking forward to seeing all of you and trusting God for good cases. All this that we're talking about, that is all technical. Where we're going to see the practice, and you guys will scrub in and see how these things are done. All right. Thank you, everybody.
Thank you, Dr. Okafor. Thank you, everyone. Have a
Good
good
night, everyone. Thank you so much for coming. See you again next week, Saturday by God's grace. Good night.
Thank you, everyone.
Thank you. George, I'm still waiting for your response to my messages, please.
Yes.
George, respond quickly, okay? So you need to write the paper quickly.
You have caught me. Yes.